So I'm going to look at muscle and bone in the linkage. So we're going to start off with Jean Campbell. Jean was an 84-year-old lady who was featured in the Toronto Star. She's the mother of a geriatric nurse clinician. She went to get her newspaper and fell forward and fractured both her wrists. Prior to that, she had been a very vibrant senior citizen, and at that moment, everything began to change. A fall can be at the beginning of the end, which it was for my mother. And this was featured in the Toronto Star. So what happened with Jean was she didn't get a bone density, and then she kept on fracturing and died prematurely. She was really well, and it really impacted on her quality of life and her family's. So Dr. Dachirik has spoken about bone strength. Fractures occur, and this is from Angela Chung, one of our colleagues in Toronto, when load exceeds the bone strength plus muscle response, your balance and falls and the direction of the fall. So sarcopenia is a relatively old concept, but it's really now taken a lot more interest. A lot of my medical colleagues don't know what it is. So everything, how many people have seen My Big Fat Greek Wedding? Any show of hands? So everything in that movie came from the ancient Greeks. And indeed, sarcopenia comes from the Greek word, poverty of the flesh, degenerative loss of skeletal muscle, and strength with aging. And it's a component of frailty. So sarcopenia is to muscle what osteoporosis is to bone. And the New York Times had a this is from the New York Times, this picture, had a very nice article last year on this. So how common is this sarcopenia? Muscle mass declines 1% per year beginning at the age of 30. So for those of you over 30, you need to start focusing. Severe muscle loss, defined as 2 standard deviations below young healthy adults, is present in 5 to 13% of 60 to 70-year-olds, and then by 80, it's 11 to 50%. But you can see there's quite a range, and part of that is how you measure it and the different populations it's studied in. I was mentioning to our new student is that I noticed when I was in France, very few people used walkers compared to North America. And is it because they're doing something different with their muscles? Do they walk to work? Do they walk everywhere, whereas we tend to rely on cars, and maybe we're accelerating this muscle loss? So there's a new consensus. This is sort of a hot topic. There was a European consensus, but there was a more recent one done by led by John Morley and the American medical directors. So they defined it as reduced muscle mass with limited mobility, so that the muscle is linked to your mobility. So the lean muscle mass less than 2 standard deviations below the mean of young adults, and this is from the US databases, and it has to be the same ethnic group. Your walking speed is less than 1 meter per second, or for those who walk less than 400 meters during a 6-minute walk test. So these are very concrete, objective ways to assess, is this an issue? And we've all seen older adults who start slowing down, who aren't keeping up, versus some adults, older adults, are just whiz in walking. Why it's important is there's a whole new interest in, can we prevent this loss of muscle? Can we keep people from falling? So clinically significant interventions increase in a 6-minute walk, you increase it by at least 50 meters, or you increase your walking speed. So how does this loss of muscle happen? Some of it is disuse, immobility. So if we're taking the car everywhere and we're not walking, that may be really happening. The Space Agency actually is very interested in this area, zero gravity. Is it nutrition an issue? Is there diseases that affect, such as diabetes? When you're sick, your steroid levels are increased. So there may be multiple mechanisms causing this problem. There's the primary, age-related, but things that affect your activity levels. Then there's diseases people get when they're older, more commonly. As well, nutrition plays a big factor. And so in treating this loss of muscle as you age and with disease, you need to target these various areas. So one of the areas which is very interesting is when I was a resident, we used to admit people and say bed rest, you know, for the first 24 hours. And still today, when people are getting admitted to hospital, you lose 2 to 5% of your muscle per day. So this is why we see a lot of older adults being admitted to acute care who were functional. The family will say, well, they were driving 2 weeks ago. You put them to bed in a week when they're sick, they'll lose 30% of their muscle mass. So the Ontario government is very concerned, and they have an initiative that day one, whether you're the nurse, the doctor, the physiotherapist, everybody helps and assists patients to get up out of bed. Because you can imagine, this just tips people over. And then the rehabilitation process is really difficult. So in terms of the muscle decline, it starts really accelerating in the 6th and 7th decade, but by 80, it really starts really accelerating. And the fastest growing group in Canada is those over 85. So this doesn't have to be the normal course. There's things that we can do to improve this course. So what does all this sarcopenia mean in real world terms? How does it affect? It is likely one of the big factors that impact on falls. So you have to look at, to reduce fractures, you need to treat the bone and also look at falls. Every 10 minutes in Ontario, at least one senior comes to the emergency room with a fall. And I would say that a lot of health professionals don't have a good approach to fall. Falls is a symptom. It's not it's due to other things. And usually when there's a cluster of 3 to 5 during a month, it means something else is happening. So some of my older patients will have had a heart attack and had a fall. And so people need to think about when they see a fall, an individual who's falling, what's going on. Were new medications added? Very common. Or patients take things over the counter that interact with their drugs. Vision is a big issue for a lot of seniors. So every 30 minutes in Ontario, at least one senior is admitted to a hospital due to a fall. So we need to think about, can we target the muscle through nutrition earlier? So medicine is very, not straightforward, but fairly straightforward. What's the biggest risk factor for a fracture? Let's see if you passed Dr. Dachi's session. Were you paying attention? The biggest risk factor for a fracture is having had one. Biggest risk factor for a fall is having had one. So asking, have you had a fall in the past year? Those with dementia and those with sarcopenia have much higher risk of falling. So when you're younger, you tend to fall forward onto your wrists. When you're older and your balance and resistance training is not as good, you may fall onto your hip and break your hip without putting your hand out. So one of our, walking is something that we recommend in the new osteoporosis guidelines, but we also recommend resistance and balance training to address this falls risk. So in our clinical assessment, these are in the new guidelines. These are the risk factors that Dr. Dachi has mentioned, but we also now ask about falls. And in the clinical assessment, we are also saying to healthcare professionals, can the individual get up from the chair? So Very easy to do the up and go, so you can time it, but you say, can the patient get out of the chair without using the armrest? And I have 100-year-old patients who can do it well, and I've had 65-year-old patients who have other medical problems who can't do that. That's very predictive of future falls and fractures. For the students in the group and for the health professionals in the group, Osteoporosis Canada at www.osteoporosis.ca has a lot of great resources. Many of the PowerPoints that you saw today are freely available on the website. The little purple 3 up from the bottom, you can go to the App Store in iTunes and Google and say osteoporosis, and you can download that app for free. And you can put in the numbers of your T-score and figure out your risk. And it gives you some of the guidelines. So falls is a very important part of assessing in terms of somebody who's had a fracture. Dr. Danchi mentioned the study by Dr. George Ioannidis, one of the statisticians with their group, about the impact of vertebral fractures. Now, I want everybody to get up. This may wake you up in the last 20 minutes. And I want you to experience what it feels like to have a vertebral fracture. So bend your knees, and I want you to lean forward. Now, how do you feel? What's starting to bother you? Your quadriceps starting to shake, you can stand up. Your back's starting to bother. And what did you feel like you were going to do? Fall forward, right? Your center of gravity is now shifted. That can be prevented. I can tell you that's how my grandmother looked. I don't want to look like that. This does run in families. So when somebody walks into your room to be seen in you can sit down. Can't leave yet. So, you know, if you're seeing somebody who looks like that, their family members are at risk. This runs in families. This can be prevented with our current treatment. Nobody really needs to look like this in the future. So this is really why when Dr. Dachi mentioned you can prevent osteoporosis, those who have had a fracture, you want to target those individuals. Because numbers needed to treat are very low. So also these fractures, as Dr. Danchi mentioned, increase the risk of death. But we know that there's something else that they're doing. And what we think they're doing is when you break something, you're not moving as much, you start losing muscle, and you become more frail. So what is frailty? So I'm a geriatrician, so this is the real plug for preventing fractures, because I think it does lead to a cascade of frailty. So frailty is really a hypothetical construct. It's a syndrome of decreased reserve and resistance to stressors, resulting from cumulative declines across multiple physiological systems and causing adverse outcomes. It's the loss of the person's ability to even withstand minor environmental stresses. So some of our older adults, they show up and emerge, and the minor environmental stress is somebody doesn't get them up walking for a week. And then it's hard to get them back home. It's strongly associated with aging, but it's not synonymous. When you've made it to 85, you're one of the survivors, and these individuals actually, many of them are not frail. Some younger patients are frail, and some older patients never become frail. Now this is Ken Rockwood's work. He's a Canadian geriatrician who's really led one of the pioneers in frailty across the country. And this was a CMAJ publication with a scale on your right. And it really shows that depending on your reserves, so if you have a caregiver or resources or you can purchase help, you may not tend to be as frail when you get a disease or illness. It's a scale of your diseases, your comorbidities, and your resources. Why is frailty important? Because those who become frail end up being prematurely admitted to nursing homes, fall, and fracture. So here's the example, the loss, and this is from my colleague, Chris Patterson, a loss of even a few % of muscle strength in a vulnerable person may convert the individual barely able to rise from a chair to a bedridden state, make them frail. And these are things, unfortunately, we do in our healthcare system, and we're hoping to change. So here's a lady of 91, and Courtney Kennedy, our PhD candidate, shared these slides with us today. So she's saying, I still have the energy I had at 50. So we tend in healthcare to see the 12% that are to 20% that are frail, but there's lots of seniors out there that maintain that vigor. Maybe not. I'm not sure I could run that now, but so, you know, I think that this individual really, this is what we aspire to be healthy and vigorous in our senior years. So how do you measure frailty? Because as clinicians, we like to measure things. It's a construct of frailty that has general consensus, but there's no agreed specific definition. There's a couple of tools that I'll walk you through. So Fried et al. Was one of the first to describe it. And if you had 3 to 5, you're considered frail, 1 to 2, pre-frail. So those who have decreased walking speed, grip strength, are not doing as much, have weight loss or self-reported exhaustion. And this could apply to other diseases like obstructive lung disease. People may go in and out of frailty, so you don't, if you have this, you can improve. Ken Rockwood developed a frailty index, which is a broader approach when you use databases and you look at 30 to 70 deficits in the data, depending on the data set, and you create an index. The more things or deficits people have wrong with them, the higher the likelihood of frailty. And that's really from a research perspective. This diagram, these are a 7-point scale for clinicians. How do you identify frailty if you're seeing somebody in front of you? And they're looking at validating, when you see this picture of somebody helping an individual with a walker, does that mean moderately frail to most people? So often, you know, somebody who's managing well doesn't have a walker, independent. Mildly frail, needing help with some of the activities of daily living. So ADL in geriatrics means activities of instrumental, sorry, this is IADL, instrumental activities of daily living, and ADL is activities of daily living. I believe this kind of scale is very helpful to see what can we do for interventions for seniors. There's also the Edmonton Frailty Scale that includes some of those other measures that I talked about. It includes more functional performance, and it does medication reviews. So you can Google this, and this is also a helpful scale. So why measure frailty? If we can identify those grandparents, parents, before they become frail, then we can maybe target exercise, nutrition, physiotherapy. So those who say have a fracture and they are becoming frail, there are things that we can target. In terms of health services, can we as a hospital or institutions look at things that we can do across the system and in the public health point of view? So I think as the population ages, there's going to be a lot more interest in, is there interventions that we can do to prevent this cascade? So there's been a lot of interest in frailty and sarcopenia because as baby boomers age, they don't want to be dependent. They want to stay as independent as possible. We know a fracture starts that whole cascade of frailty, and people lose their independence and end up in long-term care sooner. So in order really to reduce the impact of fracture, we need to target looking at the bone, but we also need to target looking at the falls and the whole issue around muscle. Nutrition is a big issue for a lot of our seniors. Everybody's been in a hospital where the tray's left on the side of the bed and it's hard for them to get to. So this is any questions or comments. There was a recent editorial by Crome and Lally on this topic of frailty in the CMAJ.